Hello again, everyone. Welcome back to our video series where we are analyzing head anatomy for an anthro and figuring out how to make a transformation work within our lifetimes. In the first video, we described what an anthro's head would look like and how things like speech, facial expressions, physiology, and overall shape would intersect with anatomy. When needed, we will briefly review relevant aspects from that video here, but we would still recommend that you watch it at some point if you haven't seen it yet. In this second video, and the one after this, we will be going into the anatomical and tissue changes that would be needed to go from an adult human shape to an anthros, and connect those concepts to ideas for implementation like tissue engineering or surgical techniques. The goals of the chapters 2 and 3 videos are first, to give you an understanding of the relevant biology, and second, to intuit how various changes can happen based on that. Keep in mind that, in many cases, we are making proposals for how things can be done. While some are high confidence, others are more speculative. These ideas represent our current thinking for the things that are most worth pursuing, and obviously that will shift a bit as we go on. A not so secret motivation for these videos is to give a shared base of knowledge to folks who are actually working on this stuff in some way, now and in the future, inside and outside our organization. There's many types of challenges with many domains of expertise, and we need these folks on the same page. We will discuss several tissue systems, bones, cartilage, and muscles and tendons in this chapter 2, and the nervous system and the visible portion of the eye, that is the anterior segment, in chapter 3. Some things will be outside the scope to cover here. We consider things like adipose tissue, secretory glands, respiratory and oral membranes, and teeth to be less technically risky. We also won't discuss skin, fur, scales, feathers, whiskers, and so on here, since those are being addressed in different projects. In other words, the tissue systems we cover here are, in our view, the most important and pressing ones to truly understand for an anthropomorphic transformation of the head region. The individual parts on their own are able to be understood, and together they can yield a great result that is far more than the sum of its parts. So, let's dive in. First up, we will get into bones as well as some tissues closely related to them. More specifically, we will cover the exact adult tissues that need to change for an anthro, biological descriptions of those tissues, and how those tissues could adapt or be forced into the shapes that we need. In the chapter 1 video, we presented a few key findings relevant to the bones of the head. We found that the inside of the skull, the brain case, does not need to be changed for a satisfactory shape. As well, the inner ears, which are deep inside the temporal bones, do not need to move in position. On the other paw, as you might expect, many of the facial bones, especially the maxilla, mandible, and other bones around the eye orbits, need to be lengthened and reshaped. So, let's go through the specifics to see what we actually need to do with these tissues. We'll start with bones around the muzzle. The maxilla and mandible will be lengthened in the anterior direction, and they need to be reshaped around the nose and jaw. As well, the nasal bones will be lengthened anteriorly. Going up towards the forehead, we see that the frontal bone needs to be advanced anteriorly to get the brow shape correct. In order to make the cheeks wider, zygomatic arches, composed of the processes of the temporal and zygomatic bones, will need to be larger. As well, the parts of the mandible that the temporalis muscles attach to, the coronoid processes, need to be spaced wider laterally so that they can be centered within the larger zygomatic arches. And then the outer aspect of the sphenoid bone might need to have some thickness added to it to help keep the wider jaw muscles aligned. Fortunately, this part of the sphenoid bone is relatively thick already. That is, it's not a particularly delicate tissue, and it represents a small fraction of the overall temporalis attachment area. Around the eyes, several bones forming the orbits will need attention. Since the eyes need to be advanced forwards and spaced a bit more laterally, the orbits need to accommodate that shift. The orbital aspect of the frontal bone needs to be extended laterally and anteriorly. Same story with the orbital aspects of these other bones, the maxillary, ethmoid, lacrimal, sphenoid, and zygomatic bones. To be clear, we're only talking about very specific portions of those bones away from the brain case, so if you winced when we said sphenoid or ethmoid, don't worry. Looking inside the oral and nasopharyngeal passages, we have a few more bones to mention. In order to match the internal anatomy to a longer snout, bones making up the nose's septum, namely the ethmoid's perpendicular plate and the vomer, need to be extended. Also pertaining to the nasal passages, the inferior nasal concha bones, as well as the maxillary sinuses, will need to be shifted anteriorly and perhaps enlarged. Finally, the floor of the maxilla, forming part of the hard palate, needs lengthened. Note that the palatine bones themselves don't need any changes. There's more to this wolf than bones, of course. This isn't Halloween, at least at time of recording. Some of the other tissues that are closely associated with bones and which should be evaluated for relevance to a transformation procedure include entheses and ligaments. These shifting bones will affect a few places where muscles connect with bone, called entheses. More correctly, a enthesis is a tissue where a tendon, coming from a muscle, or a ligament attach onto a bone. The attachment is very strong and allows for a transition from the inflexible material of the bone to the flexible material of tendons and ligaments without an abrupt boundary in the materials that would promote tearing. So, let's see what's affected. First, let's check the chewing muscles, the temporalis, masseter muscles, lateral pterygoid, and medial pterygoid. Based on how the mandible needs to change in shape, the parts of the mandible with entheses for these muscles actually don't have to change, nor do the corresponding sites on the sphenoid or other bones need to change. How about the brow or forehead muscles? Again, we're just looking at the sites where the muscle and tendon tissue encounters bone. Frontalis, good. Orbicularis oculi, good. Depressor and corrugator supercilii. They have small attachment points as well, so we can work around them. Procerus, well, the place where the procerus attaches to bone is moved pretty far, but the attachment site itself doesn't change much. Lips, okay, there are a couple possible hits here. The mentalis and the depressor labii inferioris, as well as that for the platysma, which is kind of a continuation of the depressor labii inferioris, and not shown here. Let's add those to the list. Nose muscles, no, those look good. Oral muscles, probably just the mylohyoid, the muscle on the floor of your mouth. So let's add that to the list as well. All the other oral muscles have essentially identical entheses. Orbital muscles, yeah, all of those have entheses that don't need to change. And finally, we'll probably need some new entheses for the ear musculature, since several new ear muscles will be needed. We'll talk about enthesis biology and modification shortly, but for now, let's finish up this triage. We also need to check for ligaments, tissues that connect bones with a variety of other tissues, including other bones. There's a few thin ligaments on the face, the retaining ligaments of the face connecting bones like the zygomatic bone to some regions of the facial skin and separating different compartments of adipose tissue. Yeah, due to the snout having to elongate, these ligaments might be impacted. So onto the list they go. Then there are ligaments connecting the mandible to the skull, the temporomandibular, sphenomandibular, and stylomandibular ligaments, as well as ligament tissue encapsulating the temporomandibular joint. These ligaments do not need to be modified since they are in an area of the mandible we don't need to move. Finally, around the orbit, there's the superior transverse ligament of the eye, integrating with some of the connective tissue of the eye. While the orbit itself does need to move laterally, its overall size remains relatively constant. So this ligament's current length is likely sufficient for our anthro. Alright, that does it for the triage. With that out of the way, let's discuss some of the biology of these tissues relevant to manipulating them in a procedure. So what does the biology of those bones look like? Conveniently, craniofacial bones are not too dissimilar from the other bones across the body. Their shapes are definitely unique, but the underlying tissue is built approximately the same way. Like any other bone, the hardness of these bones comes from calcified matrix that is deposited from cells. These cells, osteocytes, deposit the matrix in one of a few patterns. The matrix on the very surface of the bone is applied in layers parallel with the bone surface, called lamellae. Deeper in, the matrix is applied in concentric tubes traversing through the tissue in formations known as osteons. Then towards the core of the bone, much of the internal space is open and used by other tissue, interrupted with bony reinforcements crisscrossing the internal space called trabeculae. The matrix is gradually renewed by osteocytes, with old matrix getting chewed up by osteoclasts. So as long as a bone has enough live cells in it, we can count on its natural ability to heal or renew with any manipulations we perform. Most bone is surrounded by a membrane called periosteum. The periosteum is on both the external surfaces, scalp facing and orbit facing, as well as internal surfaces, brain facing, forming part of the meninges. Periosteum has a rich blood supply, serves as a reservoir of osteoblasts and osteoclasts, as well as their precursors, and is densely reinforced with structural molecules, especially collagen. As well, the periosteum is tightly attached to the bone by anchors called Sharpie's fibers that penetrate several lamellar layers into the bone. Essentially, any surface of a bone, as long as it has periosteum, should be able to heal or renew easily as well. The periosteum is not, however, present at articular surfaces. As well, at the places where tendons and ligaments attach, the periosteum might be either very different from what the tissue is normally like, or might be totally absent. For the bones of the skull, the periosteum is also absent at sutures with other skull bones. And finally, the periosteum is at best substantially modified at the entheses where facial muscles, part of the temporalis chewing muscles, as well as some of the orbital muscles attach. All of those regions have higher densities of structural molecules and lower densities of live cells, making any tissue renewal or healing process that would affect the surface of the bone in those areas dramatically slower. We can generally avoid this problem though. More on that shortly. Lining the inner surfaces of bone is a membrane called the endosteum. It separates the bony tissue's inner surface from its internal volume, and the endosteum also lines the Haversian canals. And similar to the periosteum, it serves as a reservoir for osteoblasts, osteoclasts, and their precursors, and is structurally reinforced with collagen fibers. Basically, that means that any living bone's insides will be able to heal or renew for any manipulations we perform as well. Occupying the volume inside bones generally is bone marrow. Most famously, bone marrow contributes to making new blood cells, and indeed, some of the skull's bone marrow also contributes to hematopoiesis, especially in older animals. Alternately, depending on the location, bone marrow can be fatty instead. Meanwhile, some craniofacial bones have cavities filled with air. These include your sinuses, as well as a similar air-filled cavity just below and behind your ears. These cavities have linings of mucous membranes separating the bone tissue from the outside air. So that's a super fast overview of bone tissue. It's obviously not comprehensive, but hopefully a usable level of detail to understand how someone can start interacting with this tissue. If ligaments are your favorite kind of tissue, I have bad news for you. There's a lot less information about this tissue than bones. In Gray's Anatomy and their musculoskeletal system chapter, ligaments had a single dedicated paragraph. Bones got 12 pages. Though, to be fair, there's less to know. These are simple tissues. The basic idea is that these tissues are built from fibers of collagen 1 as well as other collagens and molecules. Fibers may be approximately parallel to each other or arranged in a few different directions, depending on the forces the ligament in question needs to resist. Ligaments have very few living cells, tenocytes, in them, and the replacement rate for collagen is very low. Healing of injured ligaments is slow. Therefore, we cannot count on natural tissue renewal to allow for accommodating growth in existing ligaments. But on the other paw, their simple composition will make engineering and working with these tissues relatively straightforward. Again, while we don't have to mess with too many ligaments, they'll still be important for procedures done to the retaining ligaments of the face. As far as entheses are concerned, again, we have implicated the mentalis, depressor labii inferioris, and mylohyoid entheses on the mandible as being potentially impacted. It's worth quickly discussing what entheses are at the tissue level. There's a range of types going from fibrous entheses to fibrocartilaginous entheses. These types correspond to the amount and direction of force that is applied to the area of bone attachment. Fibrous entheses, such as that of some parts of the masseter muscle, generally have collagenous fibers that come from a given muscle's tendon, entering the enthesis, and then directly transmitting force via Sharpie's fibers through the periosteum into the bone itself. Not all fibrous entheses use Sharpie's fibers for their structural integration, but it's always a similar idea. To have a mechanical linkage, you have to have a mechanical linkage. Technically, fibrous entheses may have an intact periosteum, but due to the mechanical stresses this tissue experiences, we have to imagine that this tissue is more geared towards structural molecules at the cost of fewer live cells. To be safe for now, we will assume that the regenerative potential of the periosteum at an enthesis is lower than elsewhere on the bone. Fibrocartilaginous entheses provide stronger attachments of muscles and tendons to bone in a smaller area. For example, the temporalis muscle attaches to the coronoid process in a fibrocartilaginous enthesis. These entheses are more complex, providing a longer, more gradual transition from the squishy material of a tendon to the hard material of a bone. Starting with the parallel collagen fibers coming from a tendon, we enter the first region of the enthesis, termed Zone 1. This zone still has highly parallel collagen fibers and few live cells. Then we enter Zone 2, where the fibers start to become less parallel, and the extracellular matrix starts to become almost cartilaginous in nature, as might be implied from the enthesis's name. Different types of collagen become more common, like types 2 and 3 taking precedence over type 1, and the fibers become less strictly parallel. This tissue is able to handle both tensile and compressive forces well. Going deeper into Zone 3, the tissue becomes more mineralized, and the types of collagen shift again. Cells throughout Zones 1 through 3 are sparse, and cell types differ based on what layer you're in. Then finally, we reach Zone 4, which is bony and even has a presence of osteoblasts and osteocytes and osteoclasts. In effect, fibrocartilaginous entheses redirect and spread out forces that initially enter the enthesis in parallel, and importantly, fibrocartilaginous entheses have sparse cell populations in at least Zones 1 through 3. Entheses are known to heal poorly after injury, and therefore we will assume that the regenerative potential of these entheses is poor. Consequently, we do not think it's reasonable to ask entheses to increase the size of their attachment areas for craniofacial changes. That said, if the mechanical function of entheses can be preserved, keeping intact the columnar transmission of force from tendons to the surfaces of bones, it should be possible to subdivide entheses into a few parts if their footprints need to be expanded for some reason. And that leads us to the question, how will we make these tissues do what we want? For existing bones and related tissues, we would really like it if they could handle all the cellular and molecular details related to a needed shape change, as long as there is some sort of external physical guide for that shape change. So, is this something we can count on? You can probably make guesses now for bone, ligament, and enthesis tissues based on what we've said so far, so let's go through each one. Again, most bones are made of living tissue. Existing calcified tissue continually renews itself, repairing microscale damage and adapting to different mechanical loads. Meanwhile, if there are any breaks in calcified tissue, new soft tissue fills the gap before getting calcified. The renewal ability is used a lot in medicine. As one example, dental braces continually apply force over a period of time such that teeth get gradually moved through the tissue as it renews. Bone is known to be a receptive tissue for implants as well, deeply interfacing with them through osseointegration. This is used in, for example, joint replacements and dental implants. Bone also repairs itself very well after injury, involving resorption of damaged tissue and large-scale generation of new tissue. A surgical technique called distraction osteogenesis takes advantage of this when doing larger-scale modifications to bone shape, such as in limb lengthening procedures or some craniofacial surgeries. So bone is a promising tissue for manipulation, but we still need to narrow this down a little bit more. A key consideration with an anthropomorphic species affirmation procedure will be making sure that all the surrounding soft tissues also change appropriately. We'll give more information about that later in this video, but for now, what we need to keep in mind is 1. Changes in soft tissue will take time, and 2. We should not interrupt the connectivity of several tissues. Are there ways of manipulating bone that can do that? Yes. Techniques like using braces or distraction osteogenesis meet those needs. In contrast, using implants that are, say, significantly larger than the bone tissue they are instantaneously replacing would damage surrounding soft tissues. That said, you could also imagine designing some implants that themselves change shape over time. Then, in picking between the braces strategy versus distraction osteogenesis, there's some other factors to consider. First, changes from braces are very slow. They can take more than a year to shift target tissues by a small amount. I personally wouldn't have the patience to grow a full-size snout with that approach. Second, braces can sometimes have poor control over what the maxilla and mandible do. For example, braces can potentially cause teeth to move in such a way that they are closer to the surface of a somewhat weakened maxillary or mandibular bone. That's generally fine for small-scale changes, but the consequences of poor control over where structural tissues build up or thin out would be severely amplified with larger changes in our anthro. So distraction osteogenesis is our lead candidate technology for most large-scale bone changes. And there's significant precedence in the medical literature for the use of this method in adults, even older adults. But there's still some more details here that are worth discussing. A few minutes ago, we mentioned how bone regeneration or remodeling for the surface of a bone will happen best when there is an overlying periosteum. Biologically, this makes sense, since stem and progenitor cells are present in the periosteum. This has also been experimentally shown. An intact periosteum encapsulating a gap in the hard tissue where distraction osteogenesis is being performed results in better bone growth as well as remodeling into mature bone. This can be taken to the extreme. If you literally gradually pull the periosteum upwards, normal to the surface of bone, then you can encourage new bone growth without even touching the original bone. As a consequence of that, we really want to keep changes in the surfaces of bones to regions where periosteum is present. Across almost everything we're looking at, that is doable. In the few places where we have to do distraction osteogenesis without that benefit, it's probably worth pulling in some periosteum from nearby or via an autograft from elsewhere within the same patient. How about places where the surface of the bone is inaccessible, at least inaccessible without causing unacceptable tissue damage? For example, the entheses for the temporalis muscle on the outside of the sphenoid bone. We can cheat a little bit. While we do need the sphenoid's surface moved out a bit, we don't have to interrupt the entheses connecting it to the temporalis muscle. We can drill into the bone to get access, liberate its outer surface, then either distract the surface outwards or apply a biocompatible material into the gap that gets absorbed into the bone. Still, we can imagine a few places where you can probably get away with implants or total bone replacements, and we haven't even discussed the idea of using implants that expand over time. Nor have we mentioned the idea of using gene or cell therapies to accelerate bone's regeneration ability. There's a lot of biologically doable options here, and we should be fine as long as we do it carefully. One quick footnote though. While these are promising methods and the biology makes sense, the degrees of magnitude and complexity of craniofacial changes for an anthro will be higher than current practice. That's worth keeping in the backs of our minds as we think about what technologies need to be developed further. Let's go back to what we identified in our triage for ligaments, that is, the retaining ligaments of the face. These are indeed true ligaments, bringing along with them difficulty in repair and remodeling, but these ligaments are not in any structurally critical or mechanically challenging areas. We can probably rely on enhancements to existing techniques that plastic surgeons and tissue engineers figure out in the next several years, working with some of the same tissues manipulated in a facelift procedure. That's it for ligaments. At least for this tissue type, there's not a lot we have to worry about. Sweet! Entheses will not be very adaptive to change either, so we don't want to modify entheses except where necessary. If entheses are injured, i.e. if there are breaks in the continuity of mechanical load transmission from tendons or ligaments through the enthesis into bone, healing will be poor. The natural healing process for entheses is very incomplete. Even after several months or years, the enthesis tissue is weaker than it was before injury. While tissue engineering approaches to repair entheses or create new ones appear very promising, those approaches will be low throughput and can't be spanned, so to speak, in anatomical areas where they're not needed. Therefore, for the existing entheses that do need modified, to be widened, if not using tissue engineering, what can we do? This is something that hasn't really come up in the medical literature, but we can reason through it. Entheses have finally developed gradients of structural molecules from the bone surface up to the tendon or ligament they are anchoring. The structure is more elegant for fibrocartilaginous entheses than the fibrous kind, but in any case, the central idea is that these structures are very much oriented in the direction of force they have to resist. It is crucial that the load from a muscle and tendon can be transmitted through the enthesis to the bone's surface. In fibrous entheses, this is simple because the fibers of a tendon remain parallel with each other right up to the point where they meet the bone's surface or the periosteum. For fibrous entheses, the strongly parallel structure of the fibers means that we can split portions of the enthesis without affecting force transmission. In fibrocartilaginous entheses, force from tendons is carried into zones 1 and 2 of the enthesis via parallel cables of collagen. Then throughout zones 2 through 4, the structure shifts from being highly parallel to being highly networked in all different directions. Splitting an enthesis would not meaningfully change force transmission in zone 1, though would result in some weakness in zones 2 through 4 around the edges of the split. Simplistically, assuming the force transmission spreads out in a cone starting at zone 2, and considering that zones 2 through 4 are a couple hundred microns in depth, this edge weakness may only apply in a region within a few hundred microns of a split. At the macro scale, this ultimately won't be a concern because entheses are way bigger than a few hundred microns. This is actually way better than we were initially afraid of. I want to take a second and point out that even if these interventions sound extreme, they have better foundations in biomechanics than techniques that are already in use in surgeries that do not preserve these force transmission lines. We believe that what we're proposing is a safer bet than current real practice, which is already considered safe enough. Of course, quantitative modeling of the biomechanics would be important to perform, and care would be needed to ensure that entheses, as modified, successfully heal and maintain their strength around these split areas. So then the question is, do we have any mechanically critical entheses we have to mess with in the head? Earlier in our anatomical triage, we found that only the mentalis, depressor labii inferioris and platysma, and mylohyoid muscle entheses on the mandible need expansion. We haven't been able to find out for sure whether these entheses are fibrous or fibrocartilaginous yet. There's not a lot of publications about this. But regardless, and thankfully, the mentalis and depressor labii inferioris muscles have very low mechanical loads. They only move the lips, so their attachment sites can be probably subdivided without biomechanical concern. As far as the mylohyoid is concerned, this muscle has a very broad attachment area going all the way around the inside of the mandible. While important for moving the hyoid bone and tongue, this muscle doesn't experience much mechanical load compared to other muscles, especially towards the front of the mouth. While we cannot expect to increase the number of muscle fibers for muscles, which would be needed for a larger mylohyoid with the same density of muscle fibers along the increased size of the snout, we can instead just spread these fibers out, driven by spreading out their origins throughout the inside of the mandible, and the fibers will thicken and strengthen in response. So overall, we see that there are a few craniofacial entheses that will need modification, accounting for the changing shapes of bones and widening of corresponding muscles. But fortunately, these entheses for each of the connections between the mandible and the mentalis, depressor labii inferioris, and mylohyoid should be capable of subdivision without harming their mechanical functions. Some new entheses will be needed for correspondingly new ear musculature and tendons. There are promising techniques to do this. We just want to be sparing with only using these techniques for the ears, if possible, since they could be too laborious to use on a nice-to-have basis for the aforementioned mentalis, depressor labii inferioris, and mylohyoid. Generally, leading ideas are to use some form of implant, which may be a decellularized scaffold or implanted cells, ideally derived from the patient's own cells and potentially bioprinted, or a mixture. Think things like electrospinning, silk, and various kinds of stem cells, along with surface preparation for good integration with bone. Such implants are promising to be far superior to some already in use surgical techniques where tendons are simply surgically connected to bone. These implants, after cells have enough time to grow, differentiate, and remodel the surrounding matrix, can produce similar enthesis tissue to that produced by embryonic development. Ultimately, based on how this field is developing, we expect that methods will be available for the creation of new entheses without our organization needing to research them. They will probably be methods that are low throughput due to some work-intensive steps in culturing cells, keeping any bioprinted scaffolds or tissues sterile and healthy, and implanting them, so we can't just spam these engineered entheses everywhere. But for the limited applications where we need new entheses, like some new ear muscles, we should be all set. As far as take-home messages are concerned for bones and anthros, here we go. In terms of triage, several bones throughout the head will need to be changed. As well, a limited number of entheses and ligaments will need changed. Bones are compatible with remodeling, tissue engineering, and multiple surgical techniques. Still, you generally want to make sure that any enlargements to bone or implants are done gradually so that nearby soft tissues can adapt. Entheses are not the best for regeneration or remodeling. For a limited number of existing entheses in areas that are not under high stress, we may want to split them up surgically to make for a larger overall muscle attachment region. Meanwhile, for new entheses needed for ear musculature, tissue engineering should be able to meet the low mechanical demands of that area. And finally, in the limited ligaments that need changed, some relatively simple tissue engineering and implants should do the trick. Next up on the agenda, cartilage. Cartilage is another structural tissue and is more squishy than bone. It's used in places in the body that need flexibility, that experience high mechanical forces, or that need to resist shear. Similar to bone, we will organize this discussion in 3 parts. First, the exact adult tissues that need to change for an anthro. Second, some biological descriptions of these tissues. And finally, how these tissues could adapt or be forced into the shapes that we need. In the head, there's a few places with cartilage spread throughout. Most obviously, cartilage is the structural tissue that gives ears and your outer nose their shapes. Cartilage is also used to reinforce the insides of the ear canals and nasal patches, and cartilage is additionally used around the voice box, trachea, as well as the epiglottis, the flap that covers the trachea when you swallow something. Finally, cartilage is used to cushion the joints between spinal vertebrae and in the temporal mandibular joint between the mandible and the zygomatic process of the temporal bone. However, only a couple specific cartilaginous features absolutely need to be manipulated: the cartilage of the outer ears and the cartilage of the nose and nasal patches. In both of those cases, the cartilaginous structures will need to be much larger and have different shapes. It is also possible that the cartilage of the temporal mandibular joint could benefit from increased width or thickness to compensate for a larger jaw, which would presumably be experiencing larger forces with biting due to the longer lever arm. However, no other cartilage, not the voice box, trachea, epiglottis, or vertebra, needs to be changed because the existing structures there match the shapes that would be needed in our anthro. So for the cartilage of the ears, the nose, and the temporal mandibular joint, what does the biology look like? For starters, there are a few types of cartilage: elastic cartilage, hyaline cartilage, and fibrocartilage. Ears, as well as the eustachian tubes, are made of elastic cartilage. Cartilages of the nose, both the outer nose as well as the nasal septum, are made of hyaline cartilage. And finally, the temporomandibular joint uses fibrocartilage. So we're hitting all 3 kinds of cartilage here. Cartilage in general is composed of a molecular matrix that is secreted and built by cells called chondrocytes. Surrounding structures made of elastic or hyaline cartilage, but not surrounding fibrocartilage, is a perichondrium. Perichondrium contains a protective layer of fibrous structural molecules, as well as a small number of fibroblasts and chondroblasts, which contribute a population of precursor cells which have a modest ability to help renew the tissue near the surface of that cartilage. Cartilage of the nose, again, is of the hyaline type. Hyaline cartilage mainly uses collagen type 2. As well, the collagen fibers, as well as the morphology of chondrocytes of hyaline cartilage, tends to be oriented in specific directions based on the kind of stress the tissue will experience. Collagen and cells at the surface of cartilage are oriented tangentially to the surface, whereas features in deeper cartilage are oriented vertically in the material. Cartilage of the ears is of the elastic type. The collagen in this cartilage is also mainly of the type 2 variety. More uniquely, a protein called elastin is also added to the matrix all throughout the cartilaginous tissue. Elastic cartilage tends to be a little bit more stretchy than other cartilage and is used in structures that experience vibration. Finally, the temporomandibular joint uses fibrocartilage. The cells in this tissue are a mixture of chondrocytes and fibroblasts, though in reality, many of these cells here simultaneously mix properties of both of those cell types. There's some things with the temporomandibular joint that don't really follow what fibrocartilage is normally made of, but in any case, this cartilage, similar to other types, has a very low ability to repair itself. Generally, the replacement of old structural molecules with new ones, especially collagen, is slow in cartilage. Moreover, the replacement of chondrocytes is slow. There's also generally a limited blood supply to the core of cartilage, though vascular networks around the surface of cartilage are present. The diffusion of nutrients and waste throughout cartilage can be assisted by physical movement of the tissue, but nevertheless, cartilage generally has a limited metabolic capacity. Realistically, that probably means that attempting to reshape existing cartilage through gradual application of force, like stretching, will not work. On the plus side, however, cartilage is a relatively simple tissue in terms of molecular makeup and cell biology. It also has relatively simple structural interfaces with surrounding tissue. And here's a big one, cartilage is not even innervated. That means that bioprinting or similar techniques will be perfect for creating implants that are applied in their essentially final form intraoperatively for patients. There's details here that still matter, for example, controlling the direction of collagen fibers, at least for any new fiber cartilage created for the temporomandibular joint, would be important for the tissue to be strong enough to function properly, though that would merely be a nice to have for the nose and ears. Presumably stealing tricks from other areas of bioengineering, namely selective application of tensile or compressive loading on tissue culture while it's developing, would help the collagen fibers orient properly. Ultimately, we expect that implants will be needed for ear and nose cartilage, which should easily meet relatively low performance demands for mechanical properties. Meanwhile, cartilage belonging to the temporomandibular joint can potentially stay in place without modification, though this should be confirmed with biomechanical experiments to ensure that the existing cartilage can resist increased forces caused by a longer mandible. If temporomandibular cartilage does need to be replaced, implants can eventually fulfill that need once they are capable of meeting the higher performance demands involved. Let's review the most important points about cartilage. Considering the tissue biology, cartilage will not efficiently remodel. We will need to use implants instead. In terms of feasibility, since these tissues are relatively simple and ear and nose cartilages do not experience very high loads, we expect that tissue engineering can meet the needs readily. And finally, we do not expect to need to augment or replace the temporomandibular joint, but we'll keep our eyes on this topic because there is still a chance. Rounding out this discussion of mechanical tissues, let's go through muscles and tendons in the head. As a reminder, muscles are tissues that can contract to exert force, while tendons act like cables connecting muscles to their target tissues. We'll again follow this pattern that we have been using. First, we'll mention the exact tissues affected in an anthro. Next, we'll describe some biological details relevant to both preserving their function and manipulating them. And finally, we'll discuss how the tissues could adapt or be engineered as needed. There are a lot of muscles and tendons in the head that will be impacted. In the Chapter 1 video, we mentioned several groups of muscles around the snout, eyebrows, inside the mouth, around the jaw, inside the orbits, and around the ears. We talked about how individual muscles had roles in specific actions in the face, such as creating facial expressions or moving the mandible for chewing. While most of these muscles and corresponding tendons are important to change in some way for an anthro, the tissues are all pretty similar, and there's a very limited number of manipulation techniques we would have to consider. Generally, for muscles that already exist in the head, they will quickly naturally grow and adapt in length and width to the changing shapes and mechanical demands of an anthro's head. In contrast, tendons will barely adapt at all. In most cases, this won't be a problem, but it's important to be aware of. In the limited cases where it's necessary, existing surgical techniques should be sufficient to perform manual manipulations of existing muscles and tendons. And finally, attention should be given to new muscles and tendons that will drive larger ears. Now we'll drill down into understanding what these tissues are made of and how they can be manipulated. There are a few types of muscle tissue that exist in the body: skeletal muscle, cardiac muscle, and smooth muscle. In the head, we only potentially care about skeletal muscle and smooth muscle. First, we should briefly touch on smooth muscle. Smooth muscle is used to control the dilation of blood vessels, the secretions made by glands such as salivary or lacrimal or tear glands, the tensioning of the tympanic membrane in your ears, the constriction of the iris, and the erection of some types of projections from the skin like hairs or feathers. We don't need to touch the tympanic membrane, and we are not discussing the skin in this video since, again, that's a separate project. Meanwhile, new blood vessels that grow in adults automatically get their correct configurations of new smooth muscle cells. That leaves us with the smooth muscles that control gland secretions, as well as the ones used for iris constriction, as being potentially relevant for our purposes. Again, we don't have space to discuss glands, but we'll come back to the iris musculature later in the Chapter 3 video. But that's all we really have to think about for smooth muscle. And that is honestly very important to establish in a video like this. We've checked into it, and we generally don't have to think much about smooth muscle for craniofacial changes in anthropomorphic transition procedures. And that leaves skeletal muscle. Skeletal muscle is composed of bundles of aligned muscle fibers, with each fiber being somewhere between 10 and 100 microns across. These fibers are then packed into bundles called fasciculi, which are each surrounded by a sheath called the perimysium. Within a muscle, there can be tens of these fasciculi. And finally, encapsulating an entire muscle, there's another sheath contiguous with the perimysium called the epimysium. Each individual muscle fiber is basically a cell, a really big cell that can be many centimeters long. More technically, these are syncytia, and each muscle fiber can contain hundreds of nuclei from cells that have all merged together. The nanoscale structures within muscle fibers that allow them to contract are neat. Within myofibrils, then within repeating units known as sarcomeres, there are regularly arranged polymers that, during contraction, pull on each other, shortening the overall muscle fiber length. Actin and myosin are the most commonly discussed in basic anatomy, but they don't work in isolation. All the other stuff that you can see is also important. Things like desmin and dystrophin are particularly important to understand how this system structurally interfaces with the surrounding tissue, transmitting force to it during contraction. In terms of getting this thing to contract, the short version is that muscle cells fire based on signals they receive at neuromuscular junctions, or NMJs. A molecular signal from a neuron gets converted to voltage, and that voltage spreads throughout the inside of the muscle cell through a network of T-tubules. The details are cool, but more than we need to go into right now. The important thing to remember is that muscle cells intrinsically self-organize and maintain all of these things: the polymer and contraction structures, the firing mechanisms, and other things we haven't mentioned. While they represent complex living machinery, we can treat many of these details as black boxes. With skeletal muscle contractions covered, let's go back to how muscles interface with the rest of the musculoskeletal system. And that means we need to talk about tendons. Tendons generally connect the ends of muscles to bones or even other muscles, with the caveat that some muscles connect to other tissues, like directly to the skin, without having to go through a definitive tendon first. Muscles can also connect to fascia in the face. Note that tendons are not limited to attaching to skeletal muscles, they can also attach to smooth muscles. Tendons are perhaps not as exciting as muscles or bones, but this is still really important to discuss because we can't get a complete musculoskeletal system for an anthro without having a matching set of tendons. Even for the muscles in the face with one end inserting into the skin, their opposite ends are generally anchored to underlying bone via tendons. Tendons connect with muscles mainly at myotendinous junctions, or MTJs. Force gets transmitted from muscle fibers to tendons, primarily in parallel to the main direction of strain at these junctions, MTJs are close to the ends of muscle fibers. There's also some additional force transmission that starts laterally throughout the length of muscle fibers into the endomysium and perimysium membranes before turning longitudinally to run along the muscle's length and eventually join up with the tendons. These membranes and tendons are contiguous structures after all. Zooming in at MTJs, the membrane of muscle fibers gets very folded, allowing for a larger contact region between a given fiber's membrane and the corresponding tendon's collagen fibers. At a molecular level, this provides a lot of surface area for force to get transmitted from sarcomeres through dystrophin and integrins, through the muscle fiber's cell membrane, and finally out to the structural molecules of the tendon. Tendons are mostly made of type 1 collagen and a lot of water weight, along with a minority of collagens including type 3, 5, and 22 with specific roles, as well as elastin, glycoproteins, and other stuff. The collagen molecules are organized into clusters, building upwards from fibrils made of collagen polymers, then fibers, then fascicles. They're not homogeneous throughout a whole tendon's cross-sectional profile. These fibrils, fibers, and fascicles are generally parallel to the main direction of strain. Fascicles are surrounded by stretchy sheaths. As well, a small number of small blood vessels, lymph vessels, and nerves that service the tendons course through these sheaths. The blood supply for tendons generally comes from branches of vessels serving nearby muscles, but also sometimes comes from other nearby connective tissue. The nerves entering this tissue are only sensory in nature and help provide information used for reflexes as well as pain sensing. Adult tendon tissue has some limited capacity for maintenance and healing. Live cells in the tendon, tenocytes, deposit new structural molecules, including collagen, into the extracellular matrix at a slow rate, which increases modestly in response to injury. Matrix metalloproteinases are also secreted in response to injury, which helps turn over damaged structural molecules. But to be realistic, this wouldn't be enough for us to increase tendon size based on manipulating the existing tendons. Something that gets a lot less attention in medical literature is how muscles connect with skin, or really connect with anything that isn't a bone. But obviously, how muscles connect to skin in the face is important to understand for our Anthro. Fortunately for us, in 2024, there was an excellent study that investigated how various facial muscles connect to the skin and other structures. The pattern for some of these facial muscles is that as they approach skin, they fan out into individual fascicles and muscle fibers, connecting with a broadly distributed meshwork that inserts all over the skin's target region. Each little muscle fiber is separately attached to connective tissue involving collagen that connects with the dermis's collagen network. As far as I can see, these connections are not tendons per se, but they are collagenous muscle attachments and, in some respects, could behave as if they are hundreds of tiny independent tendons. There are some other things about muscles we don't have space to cover here, like pennation angles and fast twitch versus slow twitch fiber type. Details like those are important for engineering any new muscles needed, but not necessary to get an initial intuition across for the underlying biology and anticipate how biology might interact with transformation techniques. Those, again, are what we're focusing on for this video. And that leads us back to that same crucial question as for the other tissue types. How will we make these tissues do what we want? For existing muscles and tendons, we would really like it if they could automatically widen and thicken in response to a changing body. So is this something we can count on for muscles, for tendons? You've probably already got a sense on this, so let's get into it. Let's first zoom in to how skeletal muscle tissue will adapt. How can this tissue get longer? And how about wider? We know that muscle cells self-organize and maintain themselves nicely without us having to do anything. But can we still treat muscles as black boxes if we need them to enlarge? Probably, yeah. Muscle adaptation has been studied and the system appears well behaved. If a muscle is getting longer, existing muscle fibers get longer. And within those muscle fibers, new sarcomeres get added to the lengths of muscle fibers. It is more probable that new sarcomeres are added throughout the lengths of muscle fibers rather than being limited only to addition at the ends of existing muscle fibers. While this process is less efficient in aged tissue, the underlying cell biology works quite well. Even if this were performed on an older patient, these biological capabilities shift the challenge from how can cells even do this to the much simpler question of how can we turn on this pathway again? Now, what happens if a muscle needs to get wider? Here as well, existing muscle fibers grow to meet the need. They widen. This is by far the major way that existing muscles thicken. Muscle fiber diameter enlargement happens super efficiently. On a level of cell biology, this happens by thickening and splitting of sarcomeres within a given muscle fiber. Okay, one additional complexity on muscle width. What if you need a muscle to attach to a much wider area, wider than can be accomplished by widening of muscle fibers? We're mostly referring to the mylohyoid here. The answer for that is actually pretty simple. Since muscles are divided into fascicles, each bounded by relatively simple connective tissue, you can treat them in a similar way to some of the entheses and tendons we brought up earlier, separating some of the functional units from others without interrupting the connectivity of longitudinal structures. Such an intervention should be much easier than attempting a tissue graft, since no connectivity gets interrupted. The adaptability of muscles even extends to myotendinous junctions, which have been shown to become stronger in response to exercise. Overall, muscles are highly adaptable tissues. We can expect that they will be amenable to shape changes needed throughout the head for an anthropomorphic transformation. Techniques applied to bones or other surrounding tissues should largely be sufficient to control appropriate muscle shape changes. And all of this can happen without requiring new, independently neurologically controlled motor units in the face. For tendons, we expect a bit less of a smooth ride, but still not terrible. For starters, the rate at which molecules are replaced in tendons is quite slow. While there's ways to increase that rate a bit or use other regenerative processes, they're almost certainly not sufficient for stretch-induced shape change. Then, based on a review paper from 2015 at least, some of the surgical techniques available for tendon lengthening look basic. While natural tendon tissue is very strong, with contiguous cables of collagenous fibers extending uninterrupted for much or all of the tendon's length, basically all of these surgical techniques interrupt that cable and have force transmitting laterally from one severed cable to the next severed cable. Such surgeries make sense for restoring some level of function after trauma, but these are currently not methods that maintain or restore full function. Together, these factors mean that we cannot rely on tendons to naturally adapt to shape changes associated with shifting craniofacial morphology for an anthro. While most tendons we're looking at have a satisfactory shape currently, we may run into issues with tendons corresponding to some particularly wide muscles, especially around the snout, such as the depressor labii inferioris. That muscle and its associated tendon will need to cover an even larger area as the snout grows. We can get around this by splitting affected tendons along boundaries between their constituent bundles or fascicles, along with their corresponding entheses, as long as most of the longitudinal collagenous fibers are not interrupted. This would split the tissue from one tendon into several, resulting in a broader area being covered overall with a similar level of mechanical strength. In areas where you need greater mechanical strength, splitting tendons would not be sufficient. You would need legitimately thicker tendons in some other areas of the body, whether tendons are thickened by some genetic or cellular therapy applied in vivo, or auxiliary tendon tissue created with bioprinting is implanted. But here in the head, for the forces craniofacial muscles and tendons experience, the existing tendon strength should be good enough. We should make a brief comment about how facial musculature connects with the overlying skin. Again, the attachment regions for facial musculature are very well distributed across their insertion targets. There is nothing like a concentrated enthesis we have to worry about moving around. Based on the ability of skin to remodel and grow, as well as what we discussed earlier about muscle fiber growth, it is safe to say that facial muscle fibers will track with any induced growth of the skin and musculature, remaining evenly distributed around the target area as it enlarges. We should call out one other important consequence of facial muscle anatomy. Since this musculature forms a dense meshwork and muscles interdigitate with each other as they approach the skin, it would be very difficult to engineer new facial muscles with matching insertion networks. Thankfully, based on our analysis in the first video in this series, existing facial musculature should be sufficient for behavior, physiological function, and getting an excellent result faithful to someone's identity. Engineering of new facial musculature should be unnecessary for anthros. Only in terms of ear movement do we expect to need new muscles and tendons in the head. Not needing more broad applications of new muscles and tendons is a big relief, since engineering new tissue is still newish technology. Let's spec out these ear muscles real quick. Starting on the skull, we need new tendon tissue as well as new entheses on the skull itself. Building upwards, each tendon's fibers and fascicles need to be roughly parallel and extend from the skull up to meet the new muscles at their myotendinous junctions. On the other side of these junctions, we need to have skeletal muscle fibers that together comprise one of several muscles in the outer ear. The ends of these muscles have to insert onto something, of course. While there's several possible muscles to be engineered, depending on how closely the engineering has to be bio-inspired, they all insert onto cartilage, whether the ear's auricular cartilage or the scudiform cartilage. There's a surprising lack of detailed information in the medical literature about how muscles naturally connect to cartilage. Based on looking at some histology, though, the connectivity does look pretty simple, with muscles inserting onto the ear's cartilage in small concentrated positions, potentially with a small tendon or short transition zone through fascia. Ultimately, these sites don't experience that much mechanical strain compared to other areas of the musculoskeletal system, so more robust transition zones, which would require more sophisticated engineering, might not be needed. There is still the question of how to drive these muscles. Natural muscles, again, are innervated at neuromuscular junctions. And natural muscle systems also utilize feedback from sensory neurons and muscle spindles, as well as, to a lesser extent, tendons. We really want to stay away from trying to connect new neurons to the nervous system, so how else can the muscles be controlled? The simplest option is with electrodes, namely stimulating electrodes, to trigger muscle contraction. Meanwhile, feedback on the muscle's elongation can be gathered with strain sensors, and information on when to move an ear, to rotate it, to flick it, or angle it in a direction can be gathered with recording electrodes listening to other muscles nearby as well as other sensors. A possible risk with this electrical engineering approach is, can muscle fibers survive without any neuron innervation, or will muscle fibers eventually undergo programmed cell death if they don't attach to, say, a motor neuron? The answer, thankfully, is they will survive. Electrical stimulation is sufficient for muscle fibers to not just survive, but thrive. In human patients that several years after spinal cord injuries, with complete denervation of the muscles and severe atrophy of muscle size, it was found that electrical stimulation can cause muscles to recover back to normal tissue morphology. That is excellent news for any situation where a muscle is not receiving motor neuron input, regardless of the cause. Seriously, the ability of muscles to do that makes our lives, and really a lot of medical applications in general, a lot easier. So yeah, electrically engineered control of new ear musculature is something that can be done. One other quick note, the skin of the ears. While detailed discussion of the skin is outside the scope of this video, it's worth mentioning that we plan on keeping the existing skin over the ears in place and use a similar strategy of gradual stretch-induced growth, preserving all the sensory innervation throughout the skin. So implanted new ear tissue will go underneath the existing stretched skin. They are systems that can be treated independently here. To wrap up the discussion for the ear musculature, the tissue engineering, electrical engineering, and implantation will still be complex, but they are tractable, the biology works, and that, I think, is absolutely thrilling. Alrighty, so where does that leave us with muscles and tendons? First, many changes to existing muscles throughout the head are of interest to getting good results during anthropomorphic transition procedures. However, these muscles are generally expected to remodel automatically or otherwise be very compatible with manipulation. Existing tendons generally do not need to be changed. However, there are a few tendons that we are considering splitting in a way that maintains their strength. Those tendons correspond to the entheses we mentioned earlier in this video that need larger footprints. Areas of other existing muscle attachments, namely where muscles fan out and attach under the face's skin, are expected to automatically remodel appropriately as well. Generally, we do not want to swap out old muscles for new ones. This is because existing muscles have lots of innervation and other tight integration with surrounding tissues. Doing so appears unnecessary though. Finally, for the ears, new muscles and tendons will be needed. However, here we expect artificial electrodes rather than natural nerve fibers can be used to control ear movement. This is because ear musculature can operate in many ways like a closed-loop system. In Chapter 2, we have analyzed various tissues in the musculoskeletal system that need to change for an anthropomorphic transition procedure. Building off of the analysis of behavior, physiology, and important anatomical constraints of the Chapter 1 video, here we broke down the anatomy into smaller parts, looked into the relevant biology of the tissues, and made proposals for how the changes could work. The most important conclusions from the analysis in Chapter 2 are, first, in terms of bones and related tissues, bones will be compatible with all sorts of manipulation, including distraction, osteogenesis, and implants. Generally, we will not have to modify entheses, but have made some proposals for the limited cases where modifications would be needed. Few ligaments would need changed, and tissue engineering or surgical approaches are expected to be satisfactory without much work on our part. Second, for cartilage, new implants will be needed for the ears and nose, but without extraordinary biomechanical demands. Third, for muscles and tendons, existing muscles are generally expected to automatically adapt as needed. A few tendons corresponding to the entheses we have to modify may need special handling. And finally, new muscles and tendons will be needed to move the ears, but will have lower biomechanical demands and can be controlled by electrodes. In Chapter 3, we continue this analysis for the nervous system as well as the visible portion of the eye, the anterior segment. And that finishes this video. Thank you so much for watching. I know this was a marathon. We hope it was enjoyable and fascinating to watch. Thank you in particular to Medic and Marlon for many countless areas of technical input. Among other parts, Marlon helped with analysis of smooth muscles and blood vessels, and Medic helped find some crucial information about skeletal muscle. Furthermore, I am grateful to Medic for thorough technical review of the script's information and concepts. And of course, thank you again to Lathrius for making the 3D wolf model possible in the first place. Thank you more broadly to folks in our community for many helpful and constructive comments, and to supporters on Patreon. If you'd like to join our community, you can go to our website and follow the links from there. And if you'd like to support our work, please consider joining as a member on Patreon. Thank you so much for your consideration. Stay tuned for Chapter 3, which is being produced in parallel with this video and will be released a few days after this one goes out. See y'all shortly, and thanks again.